Hey there, it's Teresa here. Hi, I'm Teresa Younkin. I'm a health informaticist, and you'll find me here each week bringing you the latest thought leadership on AI, fire, and healthcare. Before we dive in this week, I want to introduce you to a group that's doing some important work, and I don't think that a lot of people know about them. It's called the Health IT End Users Alliance. They're a collective of clinicians, informaticists, operational leaders, societies, advocacy groups that are working to ensure healthcare technology, especially standards, policies, and AI tools, are actually functioning in the real world. So today I'm going to draw on those statements. I'm not going to summarize them all, but I want to apply their insights to the work that I've seen and work I've led. And I believe that this work has to evolve. So let's get into it. I want to start where it hurts, and I call it the proximity gap. And that's that disconnect between the people writing policy and the people living in the workflow. When I do a presentation or I'm doing an implementation, the most powerful moment comes when someone asks me, were end users involved in designing that? That question reveals everything. Because when people closest to the problem aren't a part of the solution, we are going to build systems that break under pressure. Designing from a distance, it'll fail up close. Number one, equity isn't just a metric, it's a mandate. So, the social determinants of health consensus statement reminds us that collecting data does not equal equity. So, equity means that we're designing systems that listen and serve. So, we can't reduce disparities with disconnected EHR fields. We need data that's actually going to travel with a patient, it respects their privacy, and it actually helps to close the loop with community based care. Again, equity is not about a form field, it's about the follow up. Next, we want to test where it lives, right? The standards and reality. So, the real world testing statement, it's pretty blunt and it's really right. Too many standards are finalized before we know if they actually work. You see, we need to test exactly where it lives, not in a controlled sandbox, but in real settings where clinicians are juggling priorities and time is scarce. If you don't test it in the field, it's not a standard, it's theory. Lastly, AI is not magic, it's just math with consequences. The AI consensus statement calls for transparency, but I'd go further than that. We need to have an AI covenant, a shared commitment to build with real data, to validate with real users, and to govern with real accountability. Because I've built AI apps and I've deployed enterprise wide governance systems. At the end of the day, AI should augment human judgment, just not obscure it, because if your AI can't explain itself, it does not belong in your exam room. So, in conclusion, end users, they're the beginning. They shouldn't be an afterthought. We always use that term end users. We need to flip that because they aren't endpoints. They're the starting point for everything that works. So, if you're a builder, bring them in early. If you're a policymaker, listen with humility. And if you're an end user, your lived experience, that is expertise. I mean, look at me. I was a stay at home mom, and this is where I ended up 10 years later. The future of health, it starts where that workflow ends. So, if this resonates with you, please subscribe, follow, or message me. I also offer AI workshops for teams looking to figure out what their strategies are, or they're trying to figure out where the pilots are, or prioritizing how they're going to deploy AI in their organizations. And I also help organizations that are doing fire implementations to meet the coming deadlines. I truly believe the more we build with people doing the work, the better our systems are going to serve those who use our technologies. Thank you for joining me. I appreciate you, and I'll catch you here again next week on the flip side.